Good evening, friends, and welcome back to the Thursday evening PG teaching session brought to you from San Hospital, Mumbai. We thank the authorities at San Hospital for allowing us to conduct these classes here, and we thank Aristo Pharma for an educational grant that helps us to live webcast these classes. Today we have one case which is being presented by Dr. Rais from San Hospital, and if time permits we'll do a virtual case after that. So we start with Dr. Rais' case.
LTMJ San Hospital. So 8-year-old girl, fourth by birth order, born out of non-consanguineous marriage, hailing from Uttar Pradesh, resident of Andop Hill, Muslim by religion, Khan by community, brought by and informed by mother, who is reliable with complaints of swelling of left index finger since 8 months, cough since 1 month, and fever since 1 month. History of presenting complaints. Child was apparently normal before 8 months. When mother noticed swelling over the left lower half of the index finger, insidious in onset, initially small in size, and has progressed rapidly to current size in the past 2 months. The swelling was painless initially, but has been associated with pain, especially with movement, since past 3 months. However, there was no limitation of movements. History of trauma to the same finger 2 years ago. No history of sinus formation or discharge. No history of skin changes over the swelling. No history of local rise of temperature. No history of similar swelling in the body. Patient developed cough since 1 month, which was insidious in onset, episodic, non-spasmodic, productive with whitish sputum, not associated with blood or increased work of breathing. Also complaints of fever since 1 month, moderate grade, on and off, associated with evening rise of temperature, not associated with chills and rigor, relieved on taking medication, and child is active in the interfebrile period. There is history of loss of appetite and history of loosening of clothes present. Negative history. No history of COX or COX contact. No history of rash. No history of blurring of vision, redness of eyes, or painful micturition. No history of receiving multiple blood transfusion. No history of yellowish discoloration of eyes or skin. No history of bone pain, bleeding manifestation, or recurrent infections. Past history. There is no significant past history. ANC history. Registered pregnancy. Iron and folic acid tablets taken. 2 doses of TT taken. Antenatal scans were told to be normal. No history of GDM, thyroid disease or PIH. No history of PRC transfusion. Birth history, full term normal vaginal delivery. Cried immediately after birth. Birth weight was 2.5 kg. No history of NICU stay or no history of neonatal jaundice. Patient is immunized till date as per National Immunization Schedule. Dietary history, mixed diet, consumes 5 out of 7 food groups. Proteins, expected is 25 and observed is 27 gram. Calories, 1520 is expected and 1322 is observed. Developmental history, achieved all milestones appropriate for ages, studies in first standard and has average scholastic performance. Socioeconomic history, lives in rented house, uses common toilet, BMC water supply and low socioeconomic status according to modified Kupuswamy classification.
You can come, we'll discuss the case. Okay, so what are your thoughts on the swelling of the left index finger since 8 months? What do you think, Sagar?
Sir, it's a chronic process. So, and so like I would like to ask about associated complaints, like if there is any breathlessness or shortness of breath. So like I thought of as a CVS with clubbing.
Okay. Anyone wants to sort of correct what he said? You have a counter to what he said. We are all learning. So it's good that he brought up this point. Very good. So it will not be one finger, right? So we are not thinking of clubbing as a possibility. What else? So first is as usual, we should try to decide the anatomy. So in the finger, the swelling is due to what? Is it bone? Is it subcutaneous tissue? Is it skin? What do you think? Joint, yeah. Can be arthritis. Okay. So now take it further. So try to discuss between these anatomies and see where you can come closest. So suppose it is arthritis, or we are discussing the joint as a possible anatomy. Now take it further. What do you want to call it arthritis? Pain.
Inflammation.
What history we got? It was initially painless. So now painless joint swelling, sometimes possible, not possible.
If it's a joint effusion, it could be painless. But if it's arthritis, that is erosion of the joint, then it will be painful.
Fine. Now joint effusion also, why do we get joint effusion?
Long-standing.
Reactionary to arthritis, then it has to be original arthritis and pain. Where else do you get a joint effusion? Big effusion in the joint.
Hemarthrosis.
Hemarthrosis, injury, hemophilia, again there will be pain. So it is unlikely that there will be effusion without pain, right? Second, what about small joints? We are talking of finger. So do you get effusion in a small joint? Hardly any, right? So that is unlikely. So if there is no pain to begin with, it probably goes against a joint as a anatomy, right? What else? Can it be bone? Can be? Yeah. So what points for or against? Yeah, for this joint, anything else? When have you seen one single small joint affected in any disease? When we see joints affected, we see multiple small joints, right? So that's again another point against joint. Can it be subcutaneous tissue? Mike.
Going on for this long is unlikely. Like usually, involvement of the subcutaneous tissue would be because of some trauma or something.
Okay. So trauma and swelling would recover fast. What else? Where have you seen?
It could be an infection, but then I think infection would have either spread along the rest of the digit by this time, or it might have discharged and sinuses will start coming out.
Okay. Where else have you seen subcutaneous tissue swelling of a limb or part of a limb?
Lymphedema.
Lymphangitis, right? But then it's affecting a bigger part of the limb, not just one digit, right? Skin again can't be for so long, right? So,
I think the history would have possibly told us where the problem is, anatomy, but reasonably to expect that it must not be a joint. A single joint of that too, not the whole finger, just one of those two joints. So less likely. Could it be skin? Out of question. Why there should be a swelling? So it could be subcutaneous tissue or it could be the bone. So anatomy must be one of the two. Okay. Now comes to pathology. There is only swelling. Okay, but no pain. Which pathology causes swelling but no pain? Inflammation. Then a tumor. Okay, what tumor at that level? And therefore the question is, is it a cyst? We don't know what's the origin of a cyst, but cyst could be a swelling and no pain. Okay. Now why suddenly cyst coming up? Unlikely. Therefore it's not a cyst, it's not a tumor. We said in pathology, most common pathology is inflammation, others are tumor, degeneration, etc., which doesn't apply here. So no tumor, no swelling, cyst, unlikely, therefore must be inflammation. Which inflammation has no pain, but only swelling?
Tuberculosis, cold abscess.
Okay. I'll give you a clue. Is tuberculous lymphadenitis in the neck painful? Why? It's inflammation, no? Lymphadenitis. Why is it not painful? So, chronic inflammation has swelling but no pain. Okay. And what history would have told you it's a chronic inflammation? Swelling is inflammation or local cyst or tumor, which we said unlikely. Okay. It's not a vascular swelling. Vascular is pain and swelling. Okay, it's not swelling alone. Okay. And if it is anything to do with the nail bed, okay, then why single? Okay, you would have had all things. Though single is also known, but that is traumatic, etc. So what question would have told you that it's a chronic inflammation only? We have done this many times. Acute inflammation, pain, swelling, redness, etc. Chronic inflammation, minimal of all this, but systemic symptom, loss of appetite, loss of weight, not feeling well, etc. Tuberculous lymphadenitis comes like that. I have a swelling, I have no pain, but I am certainly having cyst. Now you said fever and cough, loss of appetite, etc. Yes. And therefore, this has to be a chronic inflammation. Now, we know the anatomy, mostly the bone, and pathology, mostly chronic inflammation. Etiology? Before fever and cough comes. Now, 8 months of swelling. So 7 months there is no fever, no cough. What chronic inflammation? Which has lasted for 4 months. It has not progressed. It has not caused. But it is locally progressing. It's increasing. So it's a local progress. Okay. Now put a possible etiology. An infection, that a common cause of inflammation is infection. Okay. Non-infective inflammation is not only one part of the bone. So it's unlikely it's a non-infective inflammation. So it must be infective inflammation. And if it's an infective inflammation, it is a slowly growing infection, which is spreading locally, but not systemically. So now we have to guess the etiology of an infection which spreads locally. I'll give you a suggestion. I have a lymph node which starts enlarging. I'm losing appetite, weight. Nothing else is happening. Over months, it starts suppurating. It starts discharging. But nothing else is happening. Okay. What must be the infection? It is not spreading. So slowly spreading, one of the slowly spreading infection is an atypical mycobacterium. Okay. Well, even a mycobacterium typical may go slowly. But what is typical of an atypical mycobacterium is a lymph node which does not spread anywhere but locally, and over months it is just locally, even starts discharging, it becomes chronic. So one of the slowly progressive infections causing chronic inflammation is an atypical mycobacterium. Okay. Of course, any typical mycobacterium also could behave for varieties of reasons. For example, if this child has already a good immunity, okay, then he localizes the disease and does not allow it to spread. And if the bacteria do not find easy entrance to the bloodstream or lymphatics, then they don't spread. Or they could have spread in an area in the body which is not causing symptoms. And now you have a fever and cough. Okay. So I think start thinking about that. Could it be a fungal infection which goes slowly? That's another, close to TB. And every time you have a chronic TB as an etiology, you have a fungus as an etiology. Okay. Do you think immunocompromised patient would have something atypical? We said suspect immune deficiency when something is atypical. Do you think this slow progress is atypical for us to? No, in fact it would have been a fast progress. So this child is not immunodeficient. Okay. Now lastly, if there is a local infection, chronic, can somebody introduce an infection at that site? I'll give you an example. Somebody got a triple antigen, okay, and pain disappeared after 2-3 days, but a small swelling remained. The doctor said, no, sometimes the swelling remained, don't worry. Over a month, the swelling remained, and it was little even increasing. You had introduced mycobacterium through your needle and caused a local tuberculous skin lesion. Okay, I think we might have seen occasionally like this. Can somebody introduce something like this, say trauma? Just give a thought to all that. Okay, I'm just giving you a simile of what kind of trauma. Well, just come to think. Okay, unlikely, but keep in mind whether there was some pinprick there. The pinprick was contaminated pin, introduced some infection, and then the whole story starts from there. I think I would have considered one of those.
Do you know what kind of trauma that child had?
There is history of trauma, but that was 2 years back. Hit by the door.
Any other thoughts on how such a history may be relevant? I'm not saying it is relevant here, but whenever there is such history, you get a little minor trauma and you get infarct in the CNS, TB, any connection? Here, any connection, any thought process? So I mean, just stretch your imagination. If trauma can increase the blood supply to that part, now at that time if there is some bacteremia happening, it makes seeding a little easier, right? How do you know in olden days when you all don't see poliomyelitis, but how did a injection, IM injection, precipitate poliomyelitis? The IM injection did not introduce poliovirus. So what did it do? It increased the blood supply to that area. There was viremia at that point. The virus through that reached that segment of the CNS and then the polio started, right? So these are some possible.
Generally such a thing happens when there is a larger blood vessel or a larger area which is outlined. Typical head injury might lead to a brain abscess because there is a hematoma there. Okay. So less likely, but the point that Rajesh is making is that's one way of getting a local chronic problem. And I think that is important, which is less likely here because there would be a very small capillary here. The bleeding would be very minimal, and especially there is no bleeding disorder, so probably not. But a brain abscess after head injury or even a meningitis is known.
Now, what about this negative history? Any thoughts on that? So, no history of rash. For what?
For any rheumatological causes also.
So you're right, but as we discussed, rheumatological joint involvement, very difficult that one single finger joint is involved for 8 months, right? Okay. Then, blurring of vision, redness of eyes, or painful micturition.
Why did you ask that?
We're just asking them. He'll tell us his reasons, but what do you all think?
Behcet's.
Behcet syndrome or reactive arthritis, Reiter's. So again, your points or discussion on that, anybody? What do you think about reactive arthritis? Okay, uveitis in a rheumatological disease, so redness of eyes. What about reactive arthritis? Mike.
Will not affect small single joint.
So very rarely small joint. Reactive arthritis is usually of large joints, that two lower limbs, okay? So again less likely. Then multiple blood transfusions.
Maybe to rule out sickle cell dactylitis.
Okay, sickle cell dactylitis, right? Okay.
So does sickle need multiple transfusions?
I was about to.
Not even a transfusion.
So no history of transfusion, but even without that, how will you rule out sickle? Sickle could go on without a transfusion at all. So then how will you rule out sickle?
There is a duration of pain, not so long, 8 months. It will resolve in 2 to 3 weeks.
Yeah. So 8 months persistent swelling is not like a sickle cell issue. No history of yellowish discoloration of eyes or skin. For sickle. Okay. So see, sickle doesn't have icterus as a routine. Okay, sickle has icterus only when there are complications. Okay, so it won't be so long. And bone pain, bleeding manifestations or recurrent infections for malignancy. So now this is a local malignancy or a systemic? There's place here also. Local or systemic?
The symptom will come in systemic.
No. So are we talking of a bone malignancy, or are we this history is for a leukemia?
The single joint swelling will not be in leukemia. There can be some benign bone tumor, but
Which will not give
present
this
with,
history.
This history.
So actually this history is for leukemia only, but leukemia again 8 months just one joint swelling is very unusual, right? So therefore, yeah. Fine. So now,
There was tenderness. Was there tenderness in the end?
yeah, last 2 months, yeah.
So tenderness, swelling means inflammation definitely, but lot many things not very typical. I thought of dactylitis because joint was not involved and there was a swelling most probably here. And dactylitis often may occur secondary to periostitis. Usually periostitis may be painful or tender, but over the later years, so probably periostitis. And many things are atypical. So if the host is not apical, the organisms has to be atypical. Whether virus, something which we have not known, bacteria, fungus, we don't know. So periostitis anatomically, chronic periostitis with some organism which is not so typical. That's what I thought. And joint is spared because joint movements are not affected.
There is rapid increase in size in the last 2 months for the swelling.
There is what?
Rapid increase in the size in the last 2 months. Okay.
I think there is, in tuberculosis, there is one thing now that immunologists talk about, and that is Mendelian susceptibility to mycobacterial disease, MSMD. Okay. I'm not sure at this point of time whether it is for a typical mycobacteria or typical, I don't recall, but I know that immunologists nowadays in a different presentation of tuberculosis want to also study whether this is MSMD. And I just thought whether we should go to that level, but I will also check, you will also check. Possibly you will know much faster, so you will tell me next week.
Is there a possibility of introduction of a foreign body? He had some injury there, some foreign body has gone there, maybe remained silent, now it is producing inflammation. Local, foreign bodies will give rise to local. So if we disregard the later systemic symptoms, then we keep at the back of our mind whether a foreign body introduction has also occurred.
If Anand Shandilya was here, he would get to his cell phone and tell me in a minute what is MSMD. I thought one of you would be doing, okay, because you are all tech savvy, okay. Maybe you can find out whether it's for typical or apical by the time, because it's so easy. Otherwise we forget, and if you don't do it again, late Dr. Merchant once told me that when you get Indian Pediatrics Journal, same night if you don't read, you will never read again. So he said make it a habit of reading at that time only.
1 week for that.
Absolutely. So, I mean, not that everybody must look at it, we will discuss this, but I just thought that Anand was very particular. If I said I'm not sure, he would in a 2 minutes tell me, sir, I found out what is right. Okay.
Yeah, tell us.
Immediate was the word with Anand. Immediate. There is no waiting. Immediate was the word with Anand. And 2 other words were, forgot. Passion and fashion. Okay, he was quite stylish and passion for everything. Anyway, that's besides the point.
So impression, 8-year-old girl, birth and developmentally normal, fully immunized, presented with complaints of swelling in the left index finger since 8 months, with a rapid increase in size since last 3 months, fever and cough since 1 month, with history of weight loss and loss of appetite, to rule out TB, dactylitis, enchondroma, malignancy and sickle cell dactylitis.
So here we discussed all this, but when you are saying this malignancy, are you meaning the bone malignancy or leukemia?
I would think of bone malignancy, sir. So that was the primary cause.
Okay.
Malignancies like chondrosarcoma can cause lung metastasis, so it will.
Okay.
How do you analyze fever and cough?
He's saying metastasis to the lung from the primary bone malignancy.
What is the lung lesion? To me, fever and cough is bronchitis. And tuberculous bronchitis is not a common presentation. Endobronchial TB is known. So where is the lesion? Is it pleura? Is it lung parenchyma? Is it bronchi? Because
At this point,
we need to know that at this point of time what has happened to it. Any guess on anything?
You heard the history of fever and cough. So sir is asking, how will you analyze that? what is happening in the respiratory system.
For example, if it's an interstitial lung, then I'm going to tie up with interstitial lung and a rheumatological process to that swelling. So I want to know whether my possible TB is not an intern. Does interstitial TB, interstitial pneumonia occurs because of TB? No?
Miliary.
Miliary. Miliary is an interstitial lung disease.
So what could this be? Fever and cough?
Miliary TB.
Agreed everyone? Miliary TB? Why not?
There could be some mediastinal lymphadenopathy pressing on one of the bronchi. It could be causing.
So lymph node pressing on the bronchus. Possible, but then what kind of a history do you want in the cough? You want a very prominent, significant cough. So you want to cross-check with him that how bad is the cough in this child.
It's not that bad. Sir.
It's not that
Mild
bad.
cough.
So when you say cough is not that bad, in the respiratory system, where is the anatomy? Respiratory system divided into airway, parenchyma, interstitium, pleura. Now bad cough
and
is
mediastinum.
airway. This is not bad cough. So airway is out. So you're left with pleura, parenchyma, interstitium and mediastinum. So which of these is likely with this history? Interstitium, what is the complaint, presenting complaint? Breathlessness. So that is less likely. Miliary TB, will the patient come with breathlessness? We will pick up a tachypnea. But why is this not miliary TB?
It has to be spread all over the body before just coming as a miliary TB.
What else? Who gets miliary TB? Nutritionally good or poor? This child, what were we told? So, not a candidate for miliary tuberculosis, right? And then again, the reverse flow of events. We discussed that the finger is quite possibly chronic infective tubercle dactylitis, in which case after that to get miliary is like a reverse flow, no? So unlikely. So interstitium is unlikely. So you're left with parenchyma and pleura. Parenchyma? Okay. And why not pleura?
It will present with chest pain.
Okay. So you don't have
Pain as a symptom.
Yeah, you don't have symptoms of pain and usually pleural disease manifests as a effusion, pain and then effusion, so breathlessness again.
So it could be still effusion, right? So why lung parenchyma? It's either lung parenchyma or effusion.
So they are saying there should be breathlessness for it to be...
Small effusion.
Small is possible, but question
Given
is...
an example, small effusion often occurs to an underlying parenchymal disease like we call as mnemonic effusion. So even if there is a small effusion that we entertain, the underlying disease is parenchymal only, not primary pleural.
And if it is primary pleural, then it's a big effusion in a healthy child. We have been given on history that this is a reasonably healthy child. So we expect a big effusion, which we expect breathlessness, short duration breathlessness, right? We'll examine her. Just call her. So Palniraman has answered that MSMD is for typical mycobacteria.
Is he replacing Dr. Anand? What will be the aim of your examination when you see the finger? There has to be something in mind which you look out for in the examination, no? Where is it? Is it the joint or is it between the joint? Is it periosteum? Is there redness, swelling, tenderness? They are the and loss of function movements. Yeah.
Can we put on these lights and two volunteers to examine? She can sit, sir. Yeah, thanks. Chalo, one from Sayan. Come, anybody, come.
First only observation.
General condition wise, the child is fairly built and nourished, and she's active, alert, and interested in the surroundings. Local.
So she is comfortable,
She's comfortable,
right?
yes.
Now, see, as soon as you speak every word, you start correlating it with what you discussed on the history. So on the history, last discussion was if the lung lesion is plural, parenchymal. So if it was a plural and if it was a effusion, then what would you have found on general examination?
The child, there would be some pain, and she would be.
So she would be less comfortable, maybe anxious, and she may be even visibly tachypnic.
Is she a bit tachypnic? See, in two situations you can't pick up tachypnea. One is when it is very fast. And it could be 80 in an infant of bronchiolitis, it doesn't look like so fast. And another is, in an older child, just a mild tachypnea. Unless you count for a minute, you won't know. We are looking at a parenchymal lesion. Okay, with pleura, without pleura, whatever. We have to have some evidence of a parenchymal disease. It's going on for a long time. Symptoms for a month. But the problem must have started even earlier. So, possibly mild tachypnea, and when you present there, look at that, 110 and 30 in an afebrile child. So look carefully, and sometimes this is one time where you really measure for a minute or so, pulse and respiration both, right? And obviously looks a bit tachypnic, which tells you that yes, it is a pulmonary problem, interstitial or parenchymal, we are not sure.
Anything you want to add?
There is a slight nasal flaring also.
There's a nasal flaring, okay. Okay. Fine. Go on now. Further general examination. You can examine her
Just to complete that, Dr. Udani, my teacher, would have said, is there an erythema nodosum? Is there a flictin? You haven't seen it. The diagnosis is staring at you. What I mean is that in an exam, good candidate would say, there is no erythema nodosum, there is no flictin. Common etiology in our situation is TB. It could be with anything else also. So add those things, you are almost to the medal level. Who wants a medal, isn't it? We want to pass. But even passing is sure when you are up to the medal, right? So I think, remember all that, right?
She looks a little pale. There is no lymphadenopathy that I could, cervical lymphadenopathy that I could find. No other some markers of TB, stigmata of TB.
Like?
Like afflictin or any skin lesions.
Clubbing
or
and
any,
all. There is
erythema.
no clubbing too.
Okay. Fine.
There's a Montu, I think, mark, but it's, no, I don't know how old it is, but it's if more than 48 hours and it's negative. Coming to the local examination.
Yeah, local. First look at the finger and then respiratory examination. So talk about the finger.
There is a fusiform swelling in the proximal phalanx of the left index finger. The skin over the swelling is a little shiny, but there is no redness. There
There's also some dilated
are
blood
engorged
vessels.
veins.
Dilated veins.
The rest of the skin over the swelling, apart from the shining, it doesn't look indurated. The skin over the rest of the arm is normal. The other finger, I mean, it's in the IV, but there's no.
Now palpate and examine.
Sir, biopsy was done yesterday from that lesion.
Sorry?
Biopsy was done from that lesion yesterday. So
Yesterday, okay. So then that's why it is extra painful. Tell her, no, talk to her that I will do it very slowly.
Sir, the swelling is hard, tender to touch, and there is also local rise of temperature.
Okay.
And,
So there are signs of inflammation.
Yes,
Okay.
There's a little restricted movement also at the joint, probably because of the swelling and the pain. There's a little
Yeah,
restriction.
the swelling is obviously involving the phalanx and not the joint, right? Yeah. Okay. Now respiratory examination. Just ask the mom if you can take off the t-shirt or no, ask her. Ask her, is it okay?
On examination, there is nasal flaring. There are some suprasternal retractions also, and the chest looks bilaterally symmetrical, or both sides moving equally with respiration.
So actually you should, how do you look at symmetry and all that?
I should be
So
doing
come. Don't skip steps and you'll never be wrong.
looking symmetric.
Okay.
It's very shallow, right?
Yes, respiratory.
Must be a pleural pain. She's not taking a big thing. She's just doing it shallow. Shallow is pleural pain. Correct? Or it could be even without pleural pain.
She's a little anxious also.
बेटा जोर से सांस लेंगे. She can do it. Where is the problem? She need not take a big breath. So she is taking a shallow breath. Okay. But as an examiner, I would ask you, no, shallow breath is, but shallow breath is holding the inspiration. She is able to do it.
See, we are sitting in a tangential position, so we are for us it is very easy to count the respiratory rate, which I counted is close to 40. And one clue is that instead of counting the chest movements, which is difficult, count the abdominal movement. Because that is easy and it is, so to say, exaggerated, making it easy for you. Now here that ribbon also moves and that gives you an easy clue to the respiratory rate in this.
Since we don't get such opportunities often, this is the time to practice your movements, chest movements. So show us. Hold the mic for him. Let him speak. No, you go on.
सीधा कर बेटा, सीधा सीधा इस तरह. Trachea feels central.
Okay.
For trachea and chest movements we have to. सांस ले. हाँ, छोड़. सांस ले. Chest movements are.
Speak.
Chest movements are bilaterally equal and.
So you have to look in all the zones, lower zone, middle zone, upper zone. Okay, not just one area.
Okay, sir. थोड़ा उठ सकते हैं क्या?
And front and back both.
सांस ले जोर से. सांस लगी क्या? छोड़. और सांस ले. सांस ले अभी. हाँ. और ले सांस ले. छोड़. सांस ले. So chest movements are adequate bilaterally.
Okay.
Both also equal, which I felt.
Fine. Now percussion. You can actually, so respiratory system is good to examine in the sitting position also. Now you made her lie down, do it there. Sir Palni Raman has corrected himself. He checked up to date. So he's saying it's usually BCG severe infection, meaning BCG spreading, or non-tuberculous mycobacteria, NTM, and occasionally typical mycobacteria.
There is some dullness coming out from the fifth intercostal space downwards on
Both
the,
sides.
on the left side more than left.
Okay. Fine. So one thing I noticed while you were doing, so we have to improve our technique, is that you are tapping on your middle phalanx. So if your middle phalanx is not fully in contact with the chest, you will get a wrong finding. So when you are going towards the edges, your middle phalanx might get lifted from the chest. So you have to take care that it is in contact. Okay? Fine. Backside. Let her legs dangle there, it will be easy for you to examine. Lift the t-shirt so that it's easy. Huh.
Again on the left side, I thought there was dullness.
Okay. Now auscultation. So again, whenever it's possible, auscultate after lifting the t-shirt. Okay, not through the t-shirt. Okay, what did you get?
So same findings, air entry significantly decreased on the left in the inframammary, axillary and infraaxillary and the posterior lung fields.
Okay.
And slightly decreased in the right infraaxillary as well.
Okay. Fine, now let's hear what his findings are and then we'll discuss what is the meaning of those findings. Thank you.
On general examination, patient was conscious, oriented to time, place and person, febrile, heart rate was 110 per minute, RR was 30 per minute, no subcostal retraction, no intercostal retraction, peripheral pulses well felt, BP 98 by 60 millimeter of mercury, which is around 50th centile, no pallor, icterus, cyanosis or clubbing, Anthropometry, weight 20.9 kg between -1 and median, height 121 centimeter between -1 and medium, BMI 14.7, impression is normal. Head to toe examination, head normal in size and shape, no facial dysmorphism, eyes and ears normal, dental caries present, grade 1 tonsillar hypertrophy present, subcentimetric cervical lymph nodes present on right side, genitals normal. Local examination, size of 3 into 3 centimeter swelling in the lower half of the left index finger, no local rise of temperature, mild tenderness present, firm to hard in consistency, non-fluctuating, transillumination absent, pain on flexion at proximal interphalangeal joint and metacarpophalangeal joint present. System examination, respiratory system inspection, chest normal in shape, decreased movements on left side, there is mild tracheal shift to right side, no dilated veins, scars or sinuses, palpation, movement decreased on left side, tactile vocal phlegmitis decreased on left inframammary, infraaxillary and infrascapular region and right infraaxillary region. Percussion, dull note heard in the left inframammary, infraaxillary and infrascapular region and right infraaxillary region. Auscultation, air entries decreased on these same areas. Rest of the systems are within normal limits.
Okay. Come. Go to the previous slide. So now, how will you interpret your findings? You got these respiratory findings. Now you have to interpret them. So what I'm asking is, where is the pathology? Is it a consolidation? Is it a collapse? Is it a effusion?
Effusion.
Hold close.
Pleural effusion.
Why?
There is
Hold close. It's on. Mic is on.
Dull note in left region and decreased air entry over there. So
Correct. So dull note and decreased air entry can be in a consolidation also.
yes.
It can be in a collapse also. So why pleural effusion?
Because it is all over the circumference or in mid-axillary, inframammary, all areas. Consolidation would be in a particular area, not circumferentially.
Very good. So in other words, what you have to say is that it is not restricted to the lobar anatomy of the lung. It is across lobes and below a particular intercostal space. So that makes it pleural. Otherwise the signs are often similar everywhere, right? So now this is a pleural effusion. And he said other side, you also said right infraaxillary also. So maybe a small effusion there also. Any foreign sounds you got? So does that mean there's no lung lesion?
There's a lot of effusion, so probably not able to hear the crepitations.
Okay. Okay. So now how will you piece the whole story?
It is majorly a pleural.
Suppose you have to summarize the story, how will you summarize it? 8-year-old averagely nourished child
With a left dactylite, left mid index finger dactylitis.
You have to add adjectives to that dactylitis, na? So, chronic,
chronic, slowly progressive, tender, dactylitis with recent onset systemic findings in the systemic symptoms in the form of fever and cough, with examination suggestive of inflammatory swelling of the left index finger with respiratory system findings suggestive of a large left-sided pleural effusion.
So most likely etiology?
Tuberculous dactylitis followed by tuberculous pleural effusion.
Okay.
Why there is a right infra-axillary percussion abnormality and left axillary, left inframammary, etc. But also right axillary. So bilateral pleural effusion. Well, there is a right axillary. So how do you interpret that? And there are no foreign sounds. Any thought?
Maybe moderate effusion in the left side and minimal effusion in right side.
So the question is there a fluid on the other side also? Bilateral effusions are known. Okay, but is it only infra-axillary? That means it's encysted. The left side is all over. Okay, that is typically a pleural effusion. But what about the right side? Only infra-axillary. So the point that I'm making is, just check on that correctly. If it's only on the right side localized lesion, it may be a parenchymal lesion, but if it was so, then the pleural region would have been on that side. So there is something amiss there. Okay. And I'm not sure. We'll have to check the findings really. Okay. But these findings don't tally well. My next question is, can a consolidation have no bronchial breathing and no foreign sounds? It looks like pleural effusion. Could it be that? Or consolidation has to have bronchial breathing and foreign sounds?
Late stage of consolidation can have only absent air entry and no foreign sounds.
Many times a typical progressive primary complex that develops a tuberculous pneumonia has a collapse and consolidation. If you look at the pathology books, TB is collapse consolidation, whereas the rest of the pneumonias are only consolidation. So depending on what is the collapse and why collapse, because it's an extension of a primary complex. And what is primary complex? A lymph node there. So lymph node pressing the bronchial segment and still the spread of infection causing parenchymal lesion. So you have a collapse caused by the enlarging lymph node and the infection has spread to the lung. So you have a pneumonia. So pathologists call tuberculosis as a collapse consolidation. And if the collapse is significant, then a clinician does not hear anything beyond that except only the impaired node. So I think we'll have to check that. But Dr. Khare said earlier that pleural effusion in TB of a long duration is always secondary to lung parenchyma. But in an acute pleural effusion, there is no lung parenchyma. No? Where is it coming from? From air. How does it reach? So tell me, he said rightly, small effusion must be having parenchymal disease, and I am searching for a parenchymal lesion in this child. Okay. And two questions. Does acute pleural effusion has no parenchymal lesion? And where does the infection go from? So in acute pleural effusion, there is a subclinical small parenchymal lesion which often is not even seen radiologically. But it's always secondary. And it's a subpleural tubercle focus, small subpleural tubercle focus, very close to pleura, and would this child be a candidate for such a pleural effusion with small subpleural tubercle focus, not visible even radiologically? And the answer is no. That is seen in a well-nourished child with good hypersensitivity. And that's why, if you see that kind of tubercle pleural effusion, and if you treat properly at the right time, there is no sequelae at all. Because the lung lesion is subpleural, it doesn't cause any sequelae. But in this child, there has to be a parenchymal lesion. And if it's a chronic parenchymal lesion, it may leave behind the sequelae. And I think that's the difference. Okay.
Pleural effusion is often an immunological reaction to a very small focus, and it is relatively acute. This child has a slowly progressing pathology. Sometimes as a manifestation of allergy it can be bilateral, but these kinds of, I would have expected this particular child to have presented much earlier with an acute manifestation of pleural effusion. Breathlessness started 3-4 days back, and this child is acutely breathless with some pain. Here most probably the things have gone on very slowly, and there could be a lesion not only here but more disseminated even on the other side. Otherwise you can have a bilateral pleural effusion rarely as a manifestation of immunological reaction, but here probably there is an underlying disease and maybe little more extensive disease that we think. Surprisingly, the child is not looking all that bad nutritionally, but it's and another rule I remember, if I'm not wrong, isolated dactylitis without anything is tuberculosis unless proved otherwise. This is what we have learned earlier. So if you rule out the common hematological problems, etc., then this itself suggested tuberculosis.
So now, okay. So these are the differentials that he has given. So enchondroma means you are talking of two pathologies.
Yeah, we can think of enchondroma also. That is a benign tumor, most common benign tumor affecting the hand bones. Then patient can have pulmonary TB. Or it can be a malignancy like chondrosarcoma, which can cause pulmonary metastasis and cause respiratory symptoms.
Just to pick up crepitations, if you did not hear crepitation, you must make the child take a deep breath. And second is, make him cough and then check the crepitation. There could be a mucus plug obstructing that lesion. Okay, so you don't see the thing. Here we are looking for a parenchymal lesion, and therefore, even if I don't have those findings, suppose, I will tell an examiner that I have looked carefully whether there are crepitations, and I have tried all maneuvers to get the crepitations heard, but I did not hear. That's fine. He may hear, you may not hear. That's not a problem, but you have already tried it. Because in this child we have to find the parenchymal lesion. Okay, even clinically. And those findings do not tell us that there is a parenchymal lesion, but logic demands there has to be a primary, visible lung lesion.
So just for discussion's sake, the malignancy of the bone, meaning enchondroma and then a separate TB pleural effusion, is possible, but then as we discussed, that TB pleural effusion, the clinical symptomatology would be different. It would be high fever with breathlessness, short history. Here we had 1 month history of fever and cough. So that history was not like a typical TB pleural effusion that we see in an older child, right? Similarly, if a malignancy has spread to the lung, secondary bone malignancy, and that has caused an effusion, then also usually those effusions are big and relatively fast and sudden. So again they'll come with a acute onset breathlessness. So the history of fever for 1 month and cough for 1 month, last 1 month, goes against malignant spread causing a pleural effusion or a typical hypersensitivity to pleural effusion. Okay. Investigations you have? Yeah.
Course in what? Patient was presented with above mentioned complaint. Chest X-ray showed massive pleural effusion on the left side. Theatron injection ceftriaxone. UST guided pleural tap was done. Coxer cup sent. HRCT done. Report awaited. And UST guided biopsy done from the left finger. Awaiting for the report. So on investigation on CBC, HB was 10.3, hematocrit 30.6, WBC 13,000, platelet 5,41,000. And triple H was negative, on Coxer cup, Mondu negative, ESR 34, USG RPLN reactive abdominal lymphadenopathy present. Total bilirubin was 0.4, SGOT was 50, SGPT 44, total protein 7.4, albumin 4, RFT BUN 9 and creat 0.7, LDH 1400 and CRP 9.5. Pleural fluid RM, color was reddish, RBC 20 to 25 RBC per hyperfill, total cells 94, out of which poly 9 and lympho 85, protein 1.07, and on biochemical analysis, cholesterol 54, glucose 89, total protein 4.6, albumin 2.7, LDH 1300, and Light's criteria, which is exudative pleural effusion.
Can you read that X-ray? Just read the X-ray.
X-ray of the left hand with swelling in the left proximal phalanx, showing calcifications, most probably bony swelling.
Yeah, before that you say fusiform dilatation of the proximal phalanx, right?
Yes.
The whole phalanx is enlarged and dilated, right?
Yeah, there is a bony lesion as well as there is a soft tissue. So soft tissue shows inflammation, but if you see bony lesion is also likely to be there. You see the bones, it shows some disruption of architecture. What is the report? Official report?
Oh,
Okay, 1 minute.
MRI was done, sir.
No, shows the chest X-ray. Okay, again, can you read this X-ray like as if you
just
were...
read this X-ray. Come, somebody who can read it, maybe come closer and just see it. Because he said it's only large pleural effusion. And we said by analysis it cannot be only pleural effusion. So now...
Come, anybody, come.
Just see closely and...
Put off this light now, please.
What are the costophronic angles?
Left-sided costophrenic angle is completely obliterated, and large area of
Speak it out as if you are reading in the exam.
So this is a PA view of the chest X-ray with well centralized and well exposed. Left-sided costophrenic angle is blunted, and right side there is no blunting of angle, but costocardiac angle is blunted, possibly lower zone collapse, because well-defined margins are visible. And Hilar
What is that?
consolidation.
So why don't you read it how you were to read? So you start with chest X-ray. You said exposed. Is it adequately exposed, overexposed?
Overexposed.
Very good, overexposed, because the spine is seen very prominently right down. Okay, so overexposed film. Then there is a
Hyperinflated.
don't go to see what is most obviously striking.
Left side.
Homogeneous opacity in the left hemithorax. Now go on describing it. What is that homogeneous opacity looking like in the left hemithorax, which is
Fluid, because there is no air bronchogram visible.
which is obscuring the heart shadow and which has a concavity towards the hilum. Okay, which means you are describing that curve and you are saying now without a air bronchogram, with obliteration of the costophrenic and the cardiophrenic angles. So you've clearly described that this is a effusion on the left side. What about the right side?
Right side there is a inhomogeneous opacity in the right lower zone and also well-defined margin.
Very good. With well-defined margins, suggesting
Collapse of the
collapse
right lower
of some bronchopulmonary segments. Okay. Now what about the left side above that homogeneous shadow? What is happening there?
That is inhomogeneous
Opacity.
No air bronchogram.
Correct. But that inhomogeneous opacity above the margin of the effusion will suggest what? We have had a discussion on this case. So in that light, what will it suggest? There could be a parenchymal lesion underlying, right? If only this X-ray is shown to you, we have not had that discussion, you can just postulate it that there may be a parenchymal lesion.
So I think when there is a right-sided definitely a lesion and a left side we cannot pick up a lesion, probably the exposure is coming in the way. From a distance I felt that even left upper lobe doesn't seem to be very clear, especially the lower part. But we are not clear on that. But the fact is, there is a lesion on the right side and an effusion on the left side, which is not likely to be caused by that right-sided lesion, and there has to be a left-sided lesion as well. And I think that is that. In TB, if possible, look for a angle between the
subcarinal angle.
Yeah, carinal angle. And here we are not clearly seeing the left bronchus, but if we could see the left bronchus and right clearly and the carinal angle is wide, okay, then you know there is a lymph node there as well. Okay, and that's a good way to pick up a subcarinal lymph node on TB.
Yeah. So see, this is the left side bronchus maybe, it's not very clear, and right side again you are not able to see. So that's why you are not able to see the subcarinal angle. What were you? Yes.
Different from this collapse.
Correct. So this is a sharp border and this thing also is between two ribs, we don't know what it is. Right?
Likely to be consolidation.
Correct. So this is likely to be a consolidation and this sharp border is possibly a
triangular shadow. Yeah. There is no concavity. If there is concavity, we would have been little more confident to call it collapse. So bilateral lung lesion, parenchymal definitely, pleural lesion also. It is not very easy to comment on this shadow, whether that is a lymph node or no. It's difficult to pick up that, but that is all that we can say. So underlying lung lesion on the left side, though expected, is not so very clear.
MRI was suggestive of TB dactylitis.
Read the conclusion.
A fairly well-defined 2.2 into 2.1 into 1.4 centimeter intramedullary expansile lytic lesion showing permeative pattern of the destruction is noted, involving entire proximal phalanx of the left second digit with multiple cortical breaks and extraosseous extension of the lesion into adjacent subcutaneous plane with resultant condural bulge. On DCE, the lesion shows late arterial phase enhancement with arterial supply from branches of digital arteries and progressive enhancement of venous and delayed phase.
So, features
Suggestive of TB dactylitis.
fine.
CT chest.
Reports awaited, sir.
Any verbal report?
Not yet.
How will you treat this child? Any other investigations you've done? GL for
Biopsy has been done.
Biopsy of the bony lesion.
Bony lesions.
And GL for AFB?
GL also report awaited, sir.
Okay.
Sputum G and pleural fluid G.
Induced sputum was done with 3% normal saline nebulization. Because if there is no enough sputum, then you may induce sputum by giving 3% saline nebulization so that she coughs and you may be able to get the sputum.
Sir, there is a question. Can we think of connective tissue disorder in this case?
I think most of the connective tissue disorders have a disseminated lesion, that is number one, not just localized one. Second is the pleural effusion is not massive. There is pleuritis with maybe a small effusion, but more of a pleuritis. And then you have a lung lesion here and a pleural lesion here. That kind of a combination again is unusual. The lung lesion in a rheumatological disorder is largely interstitial lesion, whereas here it's a lung parenchymal lesion. A pleural lesion is generally dry pleuritis or a mild effusion. Here a large effusion. So possibly not a rheumatological disorder.
And the primary lesion is non-rheumatological. This is all dactylitis. With you have arthritis and monoarthritis of a small joint going for it doesn't fit in with any of the rheumatological disorder.
And I think if your signs were right, that there were no foreign sounds, then it must have been a collapse consolidation. But we obviously see some lung lesion on the right side, left side also probably, but we are not able to pick it up correctly.
So how will you treat this child?
So firstly we have to rule out the COX to trace the COX or cup.
So now your sentence should be not rule out. Your sentence should be we should confirm. COX bacteriological diagnosis. Okay. Then?
Maybe AKT, start AKT.
How many drugs?
HRZD and HRE.
So if the microbiological diagnosis is also sensitive for like rifampicin, there's no resistance, then we'll go for HRZD plus HRE for 12 months at least.
Suppose these all tests are negative, then how will you manage further? You have a molecular test, we have a culture, everything is negative. Now what do you do? Still treat as a anti-TB treatment? Or first try antibiotics. That give an IV ceftriaxone. Okay, child is not sick. So there is no question of a bacterial infection. Okay, and many antibiotics also partially work on a mycobacteria. So we should not loosely just give antibiotic. Okay. But how will you manage then now? I have no diagnosis. Refer to a pulmonologist, yes, but
Like it's difficult to isolate the organism from a bone
it's
lesion.
difficult. That's why you are doing DNB, and tomorrow you are going to be seeing difficult cases. Okay. The point is that every tuberculosis must have evidence, but when you have tried hard, there is no likely alternate diagnosis. After waiting, then you call it a radiologically or clinically diagnosed TB. That also exists, but not without doing all that. So in this child you would say that I've looked for fungus, I've looked for cultures or bacteriology, etc. Because I recall something like tuberculosis could be imitated by other organisms, and one of them that I recall very vividly is a melioidosis. And it comes through a contaminated water or soil. And we had a child who had gone for a vacation with the family, and he used to swim there. After a day or two of vacation there, when they came home, he started running fever. Fever off and on kind of, okay, going on for a month or 6 weeks, then developed a bony lesion, then developed a large liver, and at that stage, after about 6-8 weeks, the imaging showed an abscess in the liver. Okay. Now abscess is an acute problem, but chronic abscesses are largely caused by brucella and melioidosis. Okay, earlier we used to see plague. I had heard about plague, I haven't seen plague. Okay, but those were there. So chronic abscess could be brucella, multiple abscesses, and you get large liver, large spleen. Clinically you don't see any abscess because there is no high fever, there is no tenderness. But if you look at that, so melioidosis is one, and when I saw the net that time, it exactly said, the first sentence was, it typically mimics tuberculosis. But something funny, you have a bone, you have a liver, you have a meninges, something of that kind, and a child is not so sick looking, goes about. This looks like something similar, so I wonder whether this is anything of that kind. Unusual, pleural effusion, I don't know there. But again, whether you have an atypical mycobacteria doing it, but that I don't know whether it spreads. MSMD, somebody else, they picked up. So I think it's fair enough to start anti-TB treatment. Melioidosis usually is taken care of by third generation cephalosporin, but they need to be given for 2 weeks or 4 weeks, a little long duration. And sometimes we stop short of a week or 10 days because there is no improvement, almost like a subacute bacterial endocarditis. So I feel you must rule out those options. But finally, dactylitis, what he said, till proved otherwise, local dactylitis is tubercle.
Also, in trying to investigate, suppose hypertonic saline and all, one can go to even a little invasive test like pleural biopsy or bronchoscopy to get, on the right side you are likely to get. And a small suggestion that you can still examine the parents. If you have got any evidence of tuberculosis in one of the close relative, that's an additional point very much in favor, though they may be, or even old focus or something. So close relatives, if available, let's not overlook that, because it will be a good substantial evidence to say that it could be tuberculosis.
And I think one of the good investigations when we cannot pick up TB is a family screening. And we must mention that in exam. You will do a family screening because somebody may be harboring a focus, and that's a good way to kind of consider a probability of TB in this child.
Now, why did we tap this child? Does the pleural tap give you a diagnosis of TB? Then why tap? Therapeutic tap. So when do you need a therapeutic tap?
Or there is severe respiratory distress.
Or if there is pus. We don't need to do therapeutic tape. Diagnostic tape we can.
So what I'm asking is diagnostic tap, you don't, what you get is just exudate or transudate. So how does that
It's
help
not
you?
confirmatory. Even TB also is not so sensitive test. Pleural fluid is not sensitive for TB detection.
So then why do it?
To rule out other causes.
Which
or
other
to-
cause? Huh?
Malignancy.
Okay. So one is malignancy. Second, though it is not sensitive, but whatever 10% or 12%, suppose you are in that 12%, then you get a diagnosis, no? So that's why you have to do the tap, right? So diagnostic tap to rule out malignancy, one, confirm it's exudate and send it for gene expert. In case you are in that 10%, then at least you got your diagnosis, right? Okay.
So normally would you expect tubercle bacilli to be seen in the effusion there? Why not? Because it's an immunological. But suppose you, where will you see lot many tubercle bacilli? You tapped and you saw full of TB bacilli. Where in which disease the fluid that you have tapped contains lot of tubercle bacilli? Have you heard of tuberculous empyema? So if you have a tuberculous empyema, that is studied with tubercle bacilli, otherwise you won't see tubercle bacilli. You're not suspecting that, but by chance you see that, you think of that. And of course what she said, atypical tubercle bacilli it may be possible.
What is tubercle empyema? I know tubercle pleural effusion. And I know empyema. But I don't know two together. TB empyema. Is it secondary infection? Empyema is bacterial. Okay. And TB is pleural effusion, not pus, not empyema. What is this tuberculous empyema? Must be secondarily bacterial infection. Does TB get secondary bacterial infection? Why not? Everybody gets secondary bacterial, no? Have you heard about pulmonary TB with secondary bacterial infection? Why not? So TB bacillus does not allow anybody else to come in. So who will say what is TB empyema? And who will say why not secondary bacterial infection?
Encysted diffusion.
So tuberculous empyema is a direct extension of a lung lesion to a pleural. Whereas the typical tubercle pleural effusion is not an extension of infection but an immune reaction. That's a major difference. And therefore, when the infection spreads to the pleura from parenchyma and starts multiplying there, it almost behaves like any other bacterial empyema, except that they don't look so sick. Okay, but that's why it is called tuberculous empyema, and that's why he said your chance of getting bacteria there are much higher, but when it's an immunological reaction, you almost never get it. So that exactly that. My next question is, why not secondary infection? Everybody gets secondary infection. No? Measles gets secondary infection, gets pneumonia. Okay, chickenpox gets secondary infection in the skin. TB is a chronic problem. Okay, fibrocaseous cavitatory. Okay, such a damage. Enough. And you have a commensals also waiting to pounce upon. There are throat infections there always. They will get down, they will say there is a chance. So the question that he always asked was, who gets secondary bacterial infection?
So think of wherever you have seen secondary bacterial infection, start naming, then we'll Try and understand sir's question and answer.
Immunocompromised,
Example,
like malnutrition or
malnutrition or post-measles. So, in those, why do you get secondary bacterial infection? Why do you get post-measles? Because there is so the immunity is strongly suppressed. So does that happen in in this kind of tuberculosis?
Maybe it's because of the immunity it will.
So therefore that reason is out. Where else have you seen secondary infection? HIV, which is again immune system is affected. We already discussed that. Then anywhere in the body, think and tell. Where do you get secondary infection? Where you have seen?
Congenital, some obstruction or some.
Very good. So you need obstruction to the flow. So you need obstruction in the sinuses to get bacterial infection. You get obstruction in the urinary tract to get bacterial infection. So bronchiectasis is what? Pooled secretions, stagnant secretions, right? So obstruction, stagnant secretions, these are the situations, and you are immunocompromised. Immunity is suppressed because of the original infection. So none of these conditions are being met by tuberculosis. That's why no secondary infection, right?
Would you get secondary infection in tuberculous bronchiectasis? You said just now, retained secretions, bronchiectasis. So the answer is, when you are giving anti-tuberculous drugs, they are also antibiotics, that's number one. And it's a healed bronchiectasis. What is healed bronchiectasis? The bronchial dilatation does not heal, but the tuberculosis heals. And if that person is not able to kind of drain secretions, okay, his breathing is not proper, then he would get a secondary infection. So secondary infection in a tuberculous bronchiectasis is after the tuberculosis is cured and the damage is left behind. And that's what could happen in a fibrocaseous cavitatory disease. But not when TB is on, because multiple antibiotics are on at that time. Okay? And therefore, you don't get a combined infection mostly. And you get a secondary infection after the whole thing has been cured and a damage persists. And that damage is a good nidus for an infection, be it a fibrocaseous cavitatory disease or more often a bronchiectasis.
Would you like to trace the history of this particular disease in this child? When has the infection started? How has the war gone on between the child's body and the organism? Let's try and do that. This particular child has been tuberculized more than 1 year, 8 months. The dactylitis was there for 8 months, but more than that. Earlier, he was tuberculized. The war was still going on. There was an injury and therefore hematoma. That time the organisms must have got a chance to go and spread there, because hematoma will not last for 8-9 months. The organism must have gone there and spread there. They were dwelling there. But the real breaking down of the resistance has occurred only in last 1 month, or a little earlier than 1 month, where this swelling has also come up and a lung lesion has formed. So this child has probably fought the infection for a good length of time, and now he has broken down to locally progressive tuberculosis, and here also progressive tuberculosis. So if this child was better, maybe he would have even overcome the tuberculosis had it been very good. So though this child looks fairly good, nourished, etc., the resistance has, or immunological resistance to tubercle bacilli has broken down. Also may be interested in finding out atypical bacteria in this particular, because the behavior has been little atypical in this child.
Will you give steroids for this effusion? along with ATT? No? Why? You give steroids for pericardial effusion, no? So why not for pleural effusion?
Pleural effusion is not life-threatening. It will cure.
If it's a huge effusion, it can cause cardiorespiratory compromise.
She's comfortable and there's no severe distress.
Okay. So why do you give it in pericardial effusion?
Because it's a closed space, so we need a
This is
faster
also
recovery.
closed space, no? So if there is a inflammation and healing in that pericardial space, what can it lead to?
Tamponade.
So constrictive pericarditis or healing or whatever. So you don't want all those complications there. That is why you give it there, to prevent that. But here, as you said, right now there is no compromise, and the healing will not really obstruct the lung in any way. So that is why you don't give it, right?
So you don't mind such a thing happening in pleura? You're only worried about pericardium, constriction. Okay, that means healing and damage. What about pleura? It will obstruct my lung from inflating. And what about your peritoneum? So why are you so partial to the heart and not look at the lungs? And the reason is, pericardial is a small cavity. Okay. Therefore, the inflammation is in a small cavity and almost two layers are not greatly separated. They are separated. In pleura it can do that. And therefore, that is number one. Second is, a pleural effusion, especially the strong immunological effusion, is an acute inflammation. So acute inflammation doesn't damage. It's a quick recovery. And when it's a chronic disease like this, there is a small chance of a small damage left behind, but that will be really a thickened pleura and not much of a damage to the lung below. So it will not come in the way of that. But there is a possibility that this child has been going on for a long time and if not controlled may leave behind a thickened pleura. And therefore, whenever you see such findings, you must debate between thickened pleura and a pleural effusion. Both have same findings. Okay. How will you differentiate the two? You get the idea? Pleural effusion, okay, typical pleural, the surface anatomy of a pleural disease. Okay. How will you know it's not a pleural thickening and no effusion clinically? Give a thought. If it's a large effusion, it's easy because the mediastinum is shifted. So there is no question of it being a thickened pleura. But if it's not large enough, okay, and especially left-sided effusions are a bit tricky because as such the trachea is slightly on the right. So you're saying in a left effusion that trachea is slightly to the right, so shifted is not right. Okay, then how will you know whether there is a shift or not? I have a left-sided effusion and normally placed right-sided trachea. Will you convince me that there is still a mediastinal shift? You look at the apex beat, you look at the cardiac. It's not only the thing. In fact, tracheal shift comes when there is a very large effusion. Much before that is the local shift. So do that. Okay. And the difference between a thickened pleura and a pleural effusion on clinical examination is same, but the time frame is different. Sickness is different. In thickened pleura, the sickness is over and what is left behind is thickened pleura, whereas a pleural effusion is clinically diagnosed not as thickened pleura in a symptomatic child, and therefore presence of symptoms indicates a presence of active disease like fever, etc., and therefore we call it an effusion and not a thickened pleural.
Sir, also effusion will be tachypnic, but thickened pleura won't be tachypnic.
Absolutely, largely. Thickened pleura will not obstruct that. Good. Absolutely right.
Since the point of tracheal shift came, one point in physical examination, you ask the patient to flex the neck so that the pretracheal fascia gets relaxed. Then you are able to insert your finger on either side and then ask him to extend so the trachea comes anteriorly. And then you are able to feel the trachea, whether it is shifted or no. Otherwise, if the child is like this, and it will be, you'll have to put your finger, just do that and see how trachea comes anteriorly. So, but when you do that, the pretracheal fascia is tense. So here you go and do that, and very easily you will be able to feel the trachea.
Sir, Aristo summary.
Well, I think this 8-year-old child had come with first 7 months the only symptom of an increasing swelling over the one index finger. And we started looking from that point of view. There were no other symptoms of significance, though on direct inquiry there was some loss of appetite, loss of weight. So we came to conclusion anatomically it had to be not certainly the joint, but possibly the bone, and less likely a subcutaneous tissue. So we had no skin and no joint likely, because single joint of that kind for 7 months was unlikely. So we came to a conclusion either it's a cyst which is growing subcutaneously, but again why progressively increase? There is no space for it to increase. So we said mostly the bone, okay, on history itself. Then we said the pathology is either inflammation or the tumor. A tumor of that kind only restricted to one small index finger, okay, as a benign one, will not have a systemic symptoms. And if it was a malignancy, then it could have spread somewhere easily. So we said it must be inflammation. But then why inflammation did not have any other corroborates of inflammation like pain or like heat? And we said that is because a low-grade chronic inflammation. So we came to a conclusion on the history that this child has got a chronic low-grade osteomyelitis of a single site. And then we said the etiology has to be a very slowly progressive infection. And in our epidemiology, we bang on straight to tuberculosis as the only possibility. It was not any sickle cell, isolated, single, growing like that. So we said, on history itself, it must have been a tuberculous dactylitis. Then came the fever and cough, which meant that the infection now, which was well localized, has now started spreading. Why did this happen? Because that was not treated as TB, and therefore the infection was allowed to spread, the nutrition was suffering, so that immune system was going down. To begin with, immune system must have been good to localize the lesion. Thereafter, immune system possibly was going down, and the organism started spreading, and they spread to the lungs, and we started getting fever and cough. Then we discussed that that gels well with a possible diagnosis of tuberculous dactylitis, now spreading to the lungs. And when we talked about the lungs, we said that cough was not severe, so it's unlikely an airway. And then breathlessness was not severe, mentioned on the history, so we said it must be a parenchyma or a pleura. And both were equally possible, but when we said both were possible, we knew that pleural effusion was not possible as an isolated pathology. It had to be parenchyma or parenchyma with pleura. And therefore we diagnosed almost on the history itself. The findings convince us that findings were localized in a pleural distribution. So there was definitely a pleural lesion on the left side. Child was a bit tachypnic, so again meant that there was some distress coming up, though no obvious severe clinical respiratory distress. But the findings were also on the right axillary area, and therefore we said that must be a parenchymal lesion. But there were no foreign sounds and there were no bronchial breathing. So the question was there again a pleural disease there? It was unlikely because it had to be encysted. And encysted happens only on treatment, and therefore this must have been a parenchymal lesion. And why does a parenchymal lung lesion not have bronchial breathing or crepitation? We said it must be a collapse consolidation, like it is so often in tuberculosis. And then with those findings, we almost were sure it is tuberculosis spread from dactylitis to the lungs, and the X-rays almost demonstrated the lesion on the right side as well as a effusion on the left side. And then we discussed that if the investigation don't prove it, then we may have to rule out rarer infections, but very likely epidemiologically we might end up saying that it's a clinically, radiologically diagnosed tuberculosis. And that is where. We also discussed the possibility of an atypical mycobacteria, and we discussed about the MSMD, the Mendelian sensitivity to mycobacterial disorder and immune disorder, and all those are possibly the next step if the investigation don't give us a final diagnosis, or if the treatment does not work well, then we should go along it. We just discussed also the possibility of such multi-system involvement like bone, the lungs, sometimes the liver, brain, and that also happens in brucella, that also happens in melioidosis, very closely simulating tuberculosis, but they are rare, but we must rule it out once for all, and I think that's where we said.
Thank you, sir. So with that, we stop this class today. So thank you all our online viewers and online faculty, and we meet once again next Thursday. Thank you to Aristo for the scientific grant which helps us to live webcast these classes. We meet once again next Thursday at 6 p.m. Thank you.